Well, thank you very much, Dr. Schaff, Dr. Moon. It's very humbling to give this talk with Hartzell Schaff sitting right next to me, but I'll give it a shot to talk a little bit about our approach to pericardiectomy. It's not just how I do it, but I think where this certainly niche but important field is moving. I don't have any disclosures related to the pericardium. It would be hard to. It's an interesting disease process in that the length of time that we've been thinking about the pericardium in heart patients is tremendous, but I think the science of how to treat it has really only evolved a lot in the last couple of decades. But the guy on the right is Edward Churchill at the Mass General, described the decortication of the heart for adhesive pericarditis in 1929, and soon after that published a pretty large series, mostly TB pericarditis, done by a left thoracotomy, and he's really the first to talk about being careful of the right heart in terms of doing a pericardiectomy and avoiding distension of the heart. But the evolution of this procedure, I was lucky to be on the receiving end of. So from Churchill to Gordon Scannell, he taught Bruce Lytle, and Bruce taught me much of what I know about this, but Josta Pedersen and Nix Madeira really got me to think about this as a disease that shouldn't be so complicated and shouldn't take an all-day operation to perform. And so the idea of simplifying it to do routinely on bypass was sort of the minimum of fuss, really came from a combination of these three. So I just want to tell you about a case. This is one I tackled soon after I got to Chicago. It's actually a child of one of our faculty members. So 28-year-old guy working in finance in New York, came into his PCP with some fatigue and a little ankle swelling, and his clothes were having trouble fitting and just really felt poorly, and had some abdominal distension. They got a bunch of workup and found some liver disease, and he went far down the pathway of getting liver biopsies and testing for hepatitis. Nobody looked at the chest x-ray, which showed significant calcifications, but neither did he get an echo or an MRI. And I think it's emblematic that he was taken care of at a very good hospital, but nobody thought about pericarditis in this case. And even though he had fairly classic symptoms, and when I saw him in the office, he had jugular venous distension to the angle of the jaw. That was not noted on any of his prior exams. And so he was misdiagnosed for about 3 or 4 months, came home to see his parents in Chicago, and his dad, being a heart-related person, got an echo, and we saw some calcium, and you can see this is not his MRI, but on the right side, that classic septal bounce. We really look at the triad of echo, MRI, and cath as sort of the trifecta of diagnosis in this case, because in many cases it is a diagnosis of exclusion, and we want to rule out other types of organic heart disease. We want to rule out, in particular, myocardial disease. But in some cases, you get the classic findings. This is his MRI on the left side. You can see this tremendous septal bounce. It's got a lot of dilation, both atria and ventricle. And this pattern of calcification, which is very typical, patchy calcification, it's not the eggshell all the way around the heart in most patients, but this is kind of what we have to be prepared to deal with surgically. So simultaneous right and left heart cath, while it sounds sort of antiquated, is really an essential part of our pre-op workup, because in many of these cases where it's not an idiopathic process like this, but in some cases where it is, we're really looking to differentiate constriction and restriction. And there's no better test with all the fancy MRIs that we have than a simultaneous right and left heart cath. But he had this classic dip and plateau sign for the med students and residents. Just remember those words, the square root sign, the dip and plateau. It's classic finding for constriction. But the pattern of atrial and ventricular pressures is really what differentiates restriction and constriction. He had classic findings for constriction. Another thing that we find very useful, you saw the CT earlier, but an understanding of the distribution of calcium, and in particular in reoperations, we look at this for reentry, but for pericardial disease, it's helpful to know where are there multiple layers. That's usually a sign of old effusion, and that's somewhat more difficult to take care of. But also there can be areas of invasion into the heart. This one didn't have much. You can see it looks like it's just the pericardium, but sometimes the muscular invasion is pretty impressive. And we have to learn to work around that. Seldom do we want to pick out all those areas, but if we can remove the pericardium and leave those islands in place, it's sort of like islands in the ocean. As long as there's open water in between, the heart will beat fine. Those islands of myocardial calcification stay where they are, but we want to know where they are to start with. So we put together with Mo Alcazaz, who's a cardiologist who works with us, who's very passionate about pericardial disease, this review, Jack's state-of-the-art review a couple of years ago. It's worth taking a look at because I think it really takes you through the things we don't think about as much in terms of the imaging workup and some of the thought process around postoperative management, which is a little different for these patients. But what really gets to the crux of surgery, it's a pretty simple structure, right? It's often described as the sac that protects the heart. We really don't know if that's the case. I mean, it certainly is the sac around the heart. It has some function in lubricating the heart beating in normal patients, but that function is usually gone once you have pericarditis. So what we really have to think about is what's around it. We know it's going to be stuck to the heart on the inside, but what's on the outside that we can injure? And it comes down to the phrenic nerves, the diaphragm, and the esophagus, phrenic nerve being probably the most important of those, although I have seen cases where people have gotten in trouble with the esophagus in doing the operation I'm going to propose, which is the radical or total pericardiectomy. So we want to look at also what the sequelae of chronic constriction are when we work these patients up. Liver function tests are essential. We go down this pathway. A lot of these patients will have early cardiac cirrhosis. Remarkably, this almost always resolves after surgery. Even patients with fairly severe manifestations, ascites, a nodular liver on CT can return to normal within 3 or 4 months. It's a pretty dramatic recovery in many of these patients. And the other piece of it that we're seeing more and more of, but's important as part of the workup, is assessing inflammation. So in about 30% of our cases now, we're operating purely for inflammatory pericarditis. I'm not going to talk about that as the core of this talk, but it is a great operation for that. And really, Dr. Schaff and his team are to be congratulated for showing us that that works, and it cures patients who are on heavy-duty medication about 90% of the time. But the majority of cases we're operating on have constriction. Either way, we don't want to operate in the setting of active inflammation. So to me, the ESR and the CRP are really the most important studies there. The MRI will show inflammation months after the patient is symptom-free if they're on appropriate anti-inflammatories. But we want to see what the labs show. I don't think the guidelines are terribly helpful here for indication, so I'm going to just show this slide and then skip over it. But really what I want to get down to in the last few minutes is how much pericardium should we take out? A lot of people have been taught that this is a very high-risk operation and we should just do just enough that the heart gets better. And again, I think it's the Mayo Group that has really showed us more than anybody else that if you do that, a number of patients will come back with recurrent constriction. It's a terrible disease process. The back of the heart is constricted, the anterior part of the heart is not, and it looks like sort of like a blueberry muffin shape. It's very difficult to treat. The phrenic nerves are involved in the scar tissue, and it's a high risk for injury. So we want to do it right the first time. So the question is, if we're going to do it right the first time, should we be very concerned about bleeding and avoid bypass at all costs, or do we put the patient on pump to make it an easier, safer operation routinely? So we looked at this when I was in Cleveland over several years, and there's a more recent publication of some of this data, but I'll just show you briefly. Essentially what we found was that doing a complete resection results in better survival. And you see that kind of slowly over the long term, that those patients with partial don't do as well. But we saw, importantly, no difference between on-pump and off-pump. There was a little bit higher transfusion rate in the on-pump patients, hard to differentiate because they're often more complex, but no difference in survival. So I think this tells us we can use the pump with some degree of freedom to make this operation safer. What does really matter is the etiology. So a patient like we're talking about has a fairly low risk and good long-term survival. A patient with radiation-related constriction has a dismal 5-year survival. And I would argue we should think very carefully if we're doing isolated pericardiectomy and radiation. So let's get to technique. So we want to remove as much of the pericardium as we can, essentially all the pericardium. I use bypass routinely for 99% of these cases. And question is, what do we do with the phrenic nerves? So for me, this is going to be a median sternotomy. I think I'll show a brief video at the end, but I think the illustrations almost show it a little better. We open the pericardium anteriorly, we'll cannulate the aorta. We use femoral cannulation a lot these days just for convenience, but bicable works very well. And then in my hands, I found it's easier, and I learned this from Dr. Pedersen, to create a pedicle with the phrenic nerve on just remove the fat from the outside of the pericardium. It's very reproducible. It's harder in skinny people than large people, but it's doable. And I find it just makes it much more straightforward to remove the whole sac rather than trying to leave some sort of a strip of pericardium along the nerve. So we do that on the right side, and we take all the pericardium out down to the SVC, pulmonary veins, and then we'll do the same thing on the other side. Sometimes it's not so straightforward to take it off as one piece. Sometimes you get a lot of essentially calcium dust to work through, and thinking like an orthopedic surgeon and using a rongeur is the way to get through this stuff, but it can look sort of ugly in the process. But we want to do the same thing on both sides, and typically you can do a lot of the right side without bypass, but then the left side with bypass, and about 20% of the time I rest the heart with Del Nido. Sometimes it's to do concomitant procedures. Then you lift the heart up, and you really take all of the left side of the pericardium out, so you're looking at the esophagus, the pulmonary veins, the diaphragm, and I'll show this in a second in the video, but that's what it should look like at the end. So there's really no pericardium left. Doing this for constriction, you do it also for inflammatory disease where it really makes sense to take everything out, and then you get a specimen that looks like that. So this is just a brief video. I'll skip through this a little bit and show you the important parts. But so we use an oscillating saw because sometimes the innominate vein is stuck to the sternum. And then we'll cannulate the aorta and open the pericardium. Typically over the RVOT, it's pretty free. It's a good place to start to open. And then we'll carry that down. And in many cases, when you get to calcium, the right thing to do is going to be to use a rongeur to help you clear that stuff off. But I'll generally use the bovie on a very low setting, like 15, sometimes 10, to avoid getting into the heart. And we just take our time to get everything freed up. And then we'll free up the phrenic nerve pedicle. You can see that here, essentially staying about 2 centimeters away and using the bovie to get started, and then a combination of blunt and sharp dissection. And that whole phrenic nerve pedicle, you can see the nerve there on the inside, will just lay to the right. And that lets us remove the whole piece of pericardium on the right side. That's a little bit hard to show in the video how the pericardium comes out because your hand is in the way if you're doing it right. But then we'll do the same thing on the other side. This is getting the diaphragm part of the heart off. Sometimes this is where it gets a little stuck, and if the heart starts to tear, I'll just arrest the heart and do this part with the heart arrested. But we'll do that, and then once the whole left side of the heart is freed, so we're down here around the appendage, which often is sort of in its own little sac of pericardium, and then once we get all that freed up, we can get to the point where we start to take the pericardium off the diaphragm. We'll free the left phrenic nerve, and then I find it helps to start from the right to left in removing the heart off the diaphragm. Let's see. I can show you that a little better. And then as you do that, you'll get into this window underneath the phrenic. So this is into the left chest. So below us is sort of the aortopulmonary ligament. You can see the reflection of the pericardium there with the calcium. So I just pull that really hard to the right, and then with the bovie and some blunt dissection, you can again free that whole fat pedicle up to the other side. The nice thing with this is when you're done, you get everything out, you really have a view of the posterior mediastinum that's pretty unusual. So this is just taking some of that pericardium out there. And then you can see the esophagus and the veins, and we use the bipolar irrigated cautery for hemostasis there. Just another view of what the pedicle looks like. This is the right phrenic pedicle just pulled away. You can see the pulmonary veins and the SVC there. So it should be just completely free on the fat pedicle. So a couple of pitfalls. Effusive constrictive disease can be very challenging to clear the heart. So using this is sort of like a burn escharotomy of the heart, but doing a waffle weave to free up those areas can be helpful. This is usually when they have sort of acute effusion and it hasn't had a time to mature, but it can be a little painful. And the risk of coronary injury is higher in those cases. I think what we've learned with this is not only for these idiopathic patients is the long-term survival good. We've learned a few things about postoperative management that are a little different. One is that if you let these patients get distended, they can develop this actin-myosin dissociation syndrome where they get very sick. And if the index starts to drop early after surgery, we just put them on ECMO. And that we've been successful at rescuing about 90% of patients that have had that. But the way to avoid it is to put them on inotropes. And so everybody comes out of the OR on at least a low dose of epinephrine, and our goal is to keep the heart empty, fast, and tight for the first few hours. We use the irrigated bipolar a lot to deal with bleeding. That's really made this a very controllable operations, and then try to keep the arrhythmias under control. So what used to be thought of as an operation with a 10 to 15% mortality, I think in the idiopathics about 1 to 2% overall in the Cleveland Clinic series, and it's been so far 0% in our Northwestern series. So I would just encourage you to think about this operation a little differently. Use bypass liberally. try to get everything out and be careful of your phrenic nerves. Thank you very much for the opportunity to speak to this esteemed group.
Doug, where do you make a cut in the back when you're getting up to the top? How do you know you're at the end of the pericardium, or is there some identifier? I've never looked at that.
So what I do usually is just kind of work my way down the diaphragm from right to left and front to back. And then as soon as you get past the central tendon, you'll sort of be under the phrenic on the left side. And then you get into that window, you can really pull on it and pull it way over to the right. So the phrenic nerve is sort of tethered to the diaphragm, and then you can easily find the plane between the two. It's a pretty quick way to do it.
And
Dr. Schaff may have a better way.
You've also loosened up the left atrial appendage by then, because you think you could pull it right over with it.
Yeah, so you want to free the heart up completely first, and then work on taking the pericardium out. At least that's how I've done it. Dr. Schaff?
Well, do we have any comments or questions from the audience? Oh, yes.
Thank you. Do you have any experience of cardiac surgery after pericardiectomy? And do you use anything to cover the heart, like
I have. I'll answer that in two short parts. One is I'm aware of two patients where people tried to use a Gore-Tex patch to, recapitulate in some way the pericardium. Both of them developed recurrent constriction related to the patch. So I don't do anything. It's more challenging, certainly, to cannulate and get the heart dissected out. I've done a couple of mitral valves, like 5 years after this operation, and a tricuspid and a maze, I think. The right atrium stuck to the lung. It's usually not too terrible, but what I found is using femoral venous cannulation and just going on early so the right atrium's decompressed, it's not too bad. It's doable.
Thor?
Do you ask the anesthesiologist not to paralyze the patient, or do you rely on seeing the nerve?
I tried that for a while, and it seemed like there was so much variation in the anesthesia that I just rely on looking at the nerve. So we looked at phrenic nerve injury in that Cleveland series, and we had 3 documented phrenic nerve injuries. They were all in patients who had prior lung surgery or complex congenital operations. So I don't know if I cut the nerve or if it was cut before, but nobody who had a first-time operation had a phrenic nerve injury out of about 300 something.
Just one final comment. We would certainly agree with your liberal use of cardiopulmonary bypass. And 2 advantages. Once you're on bypass, you can use the cautery to dig out the spicules of calcium that sometimes penetrate into the myocardium, and you don't worry about fibrillating the heart. You can just defibrillate it. And the second point is when you're on bypass, you decompress the heart completely. And sometimes you'll see the reservoir fill to the top, like we used to see when you were operating on patients with chronic mitral stenosis that had been untreated for many years. They have a huge blood volume. You come off bypass and the reservoir is still half full. And so you've done exactly what you talked about with keeping the volume small and the ventricle small and active rather than distended postoperatively.
I find it a lot easier, well, historically, to dissect out the right side off pump because the planes are easier to identify. I mean, do you guys have any problem sort of identifying planes if you're on pump and everything's decompressed?
As long as they're not actively inflamed, I think it's usually pretty easy. The cardiologists think if it's calcified, it's going to be a terrible case. The calcified ones are easy. You can just ride the bovie right along the calcium, and usually the heart peels right off. So I like decompressing as early as possible. These days, I just cannulate as soon as I can see the aorta, put a femoral venous cannula in, and do the whole thing on pump.
Thank you very much.
Great.
Thank you.
Doug.